So thank you very much for having me. As mentioned, I've been heavily involved with the registries in the last couple of years, and I don't have too many slides. What I thought I would do today is go through a few slides, and then I actually have the demo website pulled up, which will have, there's no real patients in the demo website, just kind of some fake data that's entered in there to kind of show, for those of you who may not be part of the registry, just a little bit about what's in the registry, as well as some example reports that the registry can generate that I think can really address a lot of what Margie just talked about. Just as a brief overview, the AACVPR Registries launched about 5 or 6 years ago now, 2012, 2013, for cardiac and pulmonary respectively. And we have a large number of programs. So there's it's close to 500 programs in cardiac rehab that are in the registry with over 200,000 patients, and at least 200 programs probably now in pulmonary. These are data from really about 6 months ago, so there's probably even more than this now. But so there's a pretty sizable participation, and the retention rate has been very high in folks who do participate in the registry. And about a quarter to a third of our programs that are certified for cardiac and pulmonary rehabilitation currently participate. That's going to be real important too as an aside, although this is really focused on R2R, but Margie had mentioned some of the performance measures that we do collect now for program certification. That the registry will help with that as well. So it's sort of nice that there's a lot of utilization of these data. So why use registries? And I think Margie talked a good bit about this in the previous part of the presentation, where it allows you to sort of systematically see how your patients are doing. So part of this is important just for your own program maintenance, that you're collecting data for the actual patient care, and collecting people's baseline lipid profiles, their enrollment, blood pressure, et cetera, dietary surveys, and it allows you to sort of track each individual patient's progress. But in addition to that, from a broader standpoint, it allows you to compare how your program as a whole is doing against other programs, and it allows you to benchmark. And that's one thing that's real nice about the registry reports, is that you can kind of look at your data and see how your program performs in certain characteristics and outcomes compared to other programs, either nearby you or in your state, or in our similar size programs, or even against the national data. That then becomes an opportunity for you to do quality improvement. So Margie talked a little bit about quality improvement projects, and participating in that as part of some of the current value-based care requirements. And so you can use the registry data because you're able to benchmark your performance against how other programs are doing, to sort of identify areas where you may want to make improvements, or where you may want to change things, or focus in on a quality improvement project to try to better your program and improve your patient care. And then, as also mentioned, increasingly the government or insurers or other regulators, your hospital administration, are requiring you to document improved patient outcomes. And as Margie mentioned, just being able to say that the clinical trial data in the literature suggests that cardiac rehab reduces mortality and it reduces myocardial infarction risk, et cetera, or pulmonary rehab for that matter as well, has improved outcomes. It's becoming more important now that individual programs demonstrate that they are directly making outcomes improvement in patient care. And that's going to be real important as we transition into this bundled care situation, which right now with R2R, we're very focused on the post-MI, post-CABG bundle, which is starting in January. That there's a lot of concern that how is cardiac rehab going to be utilized? And we really think that cardiac rehabilitation is a real key part of that care transition in that initial 90 days of post-acute care. But there is cost obviously involved in cardiac rehabilitation, in that if you increase the number of people who attend cardiac rehab for the hospital, then the costs will go up. And your hospital may be concerned about that if say only 10 or 15% of your patient population currently attends cardiac rehabilitation, and you're trying to aggressively increase that's going to increase cost, but that's offset by improvements in outcomes. And so it may be very important for you to be able to show your hospital or your hospital administration that these are the benefits that we get in our program, and they may not really care about what the national benefits are, or the clinical trial related benefits are to cardiac rehabilitation, they might be more interested if you can show them, look, in our program, this is what we're doing, and this is how we're helping patients, and this is what you're getting for the cost, and that even though it may cost a little bit, it's going to it's going to improve our outcomes, and in the long run will work out in our favor. So we have to begin to think more about those more global issues. And I think, having a systematic way to collect these data will help to position you well to be able to do that. So what's in the registry? Well, and also, like I said, I'll show you some demo screen, put the demo site up in a minute. But basically, collect the types of things that you might expect. There's a lot of demographic information on the patient's comorbidities and medical conditions, what their admitting diagnosis is to cardiac rehabilitation. There are areas to be able to collect laboratory data and other clinical measures like blood pressure, height, weight, glucose levels, that type of thing, lipid profiles. And then the types of things that you do in your initial intake assessment are collected. So things like baseline functional capacity, quality of life questionnaires, psychosocial status, dietary patterns, and then other measures of healthcare utilization. So Margie spent some time talking about things like readmission and ED visits and things like that, and you can collect data on that in the registry for patients who enrolled in your program, and that might be a way that you could go to your hospital and say, hey, look, this is what we have X number of patients that have been in cardiac rehab. This is how often they go to the emergency room, or how many times somebody's been readmitted while they're in the program, that type of thing. And that becomes a nice way for you to design a quality improvement project to try to reduce that, or even just if you have very good data, to go to your hospital and say, look how good our data are. Patients that come to cardiac rehab, we do a really good job of keeping them out of the hospital. In the current proposed bundle, the planned bundle for post-MI, post-CABG, reducing readmission will be a major driver of increased outcome and value. So if you're able to do that through your program, you certainly want to be able to advertise that to your hospital administration, because that becomes a very powerful reason to increase utilization of cardiac rehabilitation. All the data that's necessary to meet the current program certification requirements for AACVPR are going to be in the registry. And I think the update is coming down like literally in the next week or two to get the registry completely updated and ready for the new program certification time window, which starts at the end of the year. But also, if you are going up for certification, if you're currently certified and need to recertify eventually, or if you are interested in becoming certified as a program for both cardiac and pulmonary rehabilitation, all of the data that you need to complete the application in terms of the performance measures, there's 4 performance measures in cardiac and 3 in pulmonary. Those data will be able to be collected in the registry. Also, if there's, as Margie talked about, things about ACC, things related to enrollment and time to enrollment, even though that's not something that AACVPR currently asks for in its application, but ACC and other interested parties might be interested in that. Margie mentioned that you might be very interested in looking at your time to enrollment and the percentage of patients referred who are enrolled in the program, because those are emerging areas of interest in terms of performance measures. That those types of data are collected. I'll show you that as well. They're collected in the registry, so it allows you, if you enter into the registry information on referrals, then you can look at things like how long does it take you to get people enrolled, and what percentage of the referrals that you receive actually enroll, and that type of thing. So it is a nice systematic way to track that information. And then in addition to what's in the registry, there are some reports that allow you to track the patient and program progress. And as I mentioned earlier, it allows you to benchmark, and you can take this to your administration or other outside parties, whether, for instance, if a local insurer wants to see what your outcomes are, they're trying to decide whether they want to cover cardiac rehabilitation, or you're negotiating with a private insurer, if you're negotiating reimbursement rates or something like that, and they're interested in what your outcomes are, that might provide you with some opportunity to show some data regarding how well you're doing and identify opportunities for quality improvement. So by the way, this slide here, there's a website here that's from the AACVPR.org, which is where you can actually get some of these reports. There's some demonstration reports, and the ones I'm going to show you are actually on there. So I put this link in the slide so that you can, for folks who have the slides, can look at this at another time if they want to see some of these reports. But I'm going to minus down the presentation and pull up the demo site. So This is the demo site, like I said, with some fake patients in here. And you can see here under the general information, you have a patient here who's a 71-year-old woman, and they have on here her referral date of August 16th, and then the enrollment date of September 17th, and then when she was discharged. So you can track things by using these types of data entry fields. If you capture when people are referred, you can look at things like time from referral to enrollment. If you collect all the information in your referrals, you can actually even figure out what percentage of your patients who are referred actually enroll and that type of thing. And then if you look across the top up here, you have the demographics, medical history tabs, etc. This is where you would go in and collect some of the information on, is it man or woman, race, etc. And the demographics. You can collect information on insurance, whether they have Medicare or other types of insurance. There are fields in here to enter the medical history, as well as what their reason for admission is to the program. And there's, once again, you have some of these information on referral and completion information, number of sessions they've completed, etc. And then these clinical tools buttons are really some of the better things where you can go in and put their lab values, blood pressure data, their medications and whether they smoke or not. All this type of stuff is in there. This is where your functional assessments are. So this is where you enter things regarding like, your functional capacity, what their METs are, their 6-minute walk test distance, that type of thing. And notice that you have fields in here for intake and a discharge. Okay, so you go in, you put your data in at baseline when they first come into your program, and then you can kind of come back when they complete the program and put in their completion data. And then the registry will calculate for you a percent change. If you do a 1-year follow-up appointment, you can come in on the time of that follow-up and enter in data for that as well. Now, I know in our current registry, we don't have a lot of people who do the 1-year follow-up, but certainly in terms of intake and discharge, it allows you to see what the numbers are in intake and then on completion. And then this last button here is your hospital utilization field, where you can enter stuff on things like unexpected events or adverse events. So this would be things like, people are hospital readmission or ED visits. So somebody is, there's like a adverse event that occurs, you can enter that type of information into here. And these hospital readmission areas are real good for you to look at for, and also ED visits. When you're starting to think about how you position yourself locally regarding the bundles, because the bundles are going to be heavily focused on doing things like preventing readmission or preventing ED visits. And so if you can show how you're doing relative to other programs, I think this could be very powerful for you to do that. And I'm not going to log into the pulmonary rehab registry, as I'm not as familiar with it, but there's similar type fields in there as well. And the focus of this, I guess, really is on the R2R initiative, which is really driven by the cardiac care bundle, and episode payment models. But the same type of thing can be said for pulmonary, in that these similar types of data are collected and are equally as powerful. And if you're participating in bundle care for COPD or any of these other pulmonary type conditions that do have some bundle care already, there are opportunities to use your pulmonary rehabilitation registry to work on that. So the next thing I wanted to show you is some of these reports. And so there's 3 reports that I was going to show you. This first one is what's called an individual report. And this would be something that you would run on a patient that you wanted to just kind of see in this individual patient, how do they do? This is something you can even print out and give to the patient if you wanted to, but it has things on here like their name up here, their risk level, what their diagnosis is, et cetera. And then as you scroll down, you can see that there's a column here for initial, okay, and then the discharge, and then the change. And then there's these little colored arrows that come in for each of these fields. So you have the enrollment date and the discharge date. You have how many sessions they were prescribed. You have like for instance, here you have an intake blood pressure and a discharge blood pressure for systolic and diastolic. You have their peak METs during cardiac rehab, 5.5 METs at baseline, which increased to 7.6 METs at the end. And that resulted in, that's better. So you get a green arrow for better. And it tells you what the percent change was. So a 38% increase in their METs. Same thing here with exercise minutes per week, et cetera. So you can kind of just scroll through this and see that each of these, anything that you measure, weight, et cetera, that might change while they're in the program, you can actually just print this out, and it's a nice way to kind of summarize how they did. You can get their lipid profile in here, their glucose, et cetera, is all in there. In addition, you can do things like their depression scores, their SF-36, et cetera. You have their baseline score. Say this one, for instance, on the PCS is a baseline score of 44 with a completion score of 56. So that's an improvement of 27%. So this is how you can look at an individual patient and show data to them or to someone else. There's also a program, what's called a program outcome summary. So this is sort of like a way to look at all of your patients in the program, just kind of in isolation to see how does your program do. And so this example gives you a date range. So you can kind of pick what range you want to have here. There's a total of 42 patients who are in this sample, and it shows you kind of what your percent of men and women are. Lots of information on demographics here, what the diagnoses are that they had when they entered cardiac rehabilitation, what their comorbidities are, et cetera, their risk factors. It just give you some idea of what percentage, if for some reason you wanted to try to better describe your patients and, what percentage of your patients have hypertension or what percentage of your patients have diabetes, et cetera, you can look at that very easily with these types of data, what their AACVPR risk level was, how many sessions you're doing on average, smoking status, et cetera. And then as you scroll down lower, you can see things on their blood pressures or lab values, and as well as how they're doing in terms of performance. So for instance, you want to go to your administration and say, for instance, in this example, for the peak METs during cardiac rehab, baseline peak METs, the average of the 42 patients was 2.4, and then on completion it's 4.6, and that's almost a doubling of the 92% increase, almost a doubling of the peak METs achieved during cardiac rehab. So you can go to people and say, look, here's our patients for this 1 year period of time. Say we had this type of improvement in functional capacity for our patients. And it's a nice way to kind of demonstrate how you're doing as a program with real hard data. And you're entering these data into the registry all the time to just track individual patients. And then you just sort of generate the report, and the registry will kick this report out, and it keeps you from having to do a whole lot of calculations on your own, and you can kind of easily show people how your program is doing. And then the last report, which I think may be the most powerful report, is this registry performance report, because what this does is it allows you to benchmark. So if you look on the top here, you have a date range, January through March, and notice it says comparison group, and this says statewide, but you could choose other programs that are similar sized, or you can even say you wanted to benchmark against the entire AACVPR registry, so the national registry. It tells you how many programs are in there. So there's 86 programs that are pulled from this statewide database. And these are going to be people who participate in the AACVPR registry. You have 51 patients here in your program, and then there's 1,254 patients that are in the statewide comparison group. So you kind of see how many you have. And then you can just look side by side. So what's our percentage of men, 75% men versus 71% for the comparison group. You can look at all kinds of racial information, diagnoses, et cetera, risk category, all of the comorbidities to see, do we have roughly the same percentage of patients who have hypertension as compared to other people, or diabetes as compared to other people. And then probably more importantly is down here on the next page, you can look at, how do you do? So for instance, at completion of the program, 93%, have an LDL, how many have an LDL cholesterol, say below 100, 93%, versus 69% in the comparison group. So you can kind of see how you're doing in the means. And on the right here, it shows you what the 25th percentile, the median, and the 75th percentile are in the comparison group. So you can kind of really see, okay, so, 93% of our patients finish with an LDL cholesterol less than 100, and the median for the comparison group was 86%. So we're doing better than the median in this comparison. And so you can look for places where you don't score very well against the benchmark and target that as opportunities for improvement. Or you can show where you're doing well and then go to whoever it is, your private insurers or your hospital administration, and try to sort of explain what it is that you're doing and where the benefit is. And you can do this for other things like functional capacity, et cetera. Here's your health outcomes section here, where you can look at things like adverse events, unexpected events, hospital admissions, ED visits. So this type of information in here is very, very valuable for you in the bundled care world, where you want to show, are you able to reduce, are you preventing hospital admissions? So you can look at how, we have, say, 6% hospital admissions or something relative to other places. That puts us, the median here is 4%, so that puts us a little bit above the median. So that might be something to target, say, hey, we kind of are on high, we're a little bit high, we're in the upper half in this comparison of hospital readmission. So we need to maybe work on that a little bit. So, and like I said, these are all fake reports, obviously, but you get the idea of what I think you can do and how powerful the registry can be as far as allowing you to show your data to other people, because as Margie mentioned, it's not simply good enough to just say that we know cardiac rehab works, but people are going to want you to demonstrate that your program is performing well. And unless you actually measure these things, you won't really know what it is you're doing well and what it is you're not doing well. And the registry allows you to measure that and also compare yourself to your peers, which is very, very valuable. So in summary, I guess I would say is that, it's really not good enough any longer to what I call simply take good care of patients. I think in the past, we knew that cardiac and pulmonary rehabilitation were effective and they worked and people did well. And so we said, okay, you do your program and take good care of your patients, and that's all nice. But nowadays, I think there's an increasing interest in people proving their worth, so to speak, or showing what your individual outcomes are, and trying to identify areas where you're not doing as well and where you can improve, and having to justify to your individual hospitals why you want to be why cardiac rehab or pulmonary rehab should be part of this value-based care model. As you mentioned, it's very important to collect data on your clinical effectiveness, and this is going to be important for program certification, because now the program certification application requires you to submit data, actual data, not just example ITPs, et cetera, but now it's going to be required to actually submit data on performance measures. So to be certified, you're going to have to collect data and submit data. And truthfully, in the future for reimbursement, this is probably going to become a larger issue, particularly in the bundled care world. I think that the registries and these reports that the registry can generate are great opportunities for you to get to your data, to collect your data, and to report your data. And I didn't mention this earlier, but you can actually, if there are these sort of reports that are pre-populated for you, but if there are things that you want to show that are not in those reports, you can export all of your data. So you can actually get all of your individual patient data exported out of the registry, and then you can do whatever type of statistical analyses or create graphs or plots, et cetera, that you want to create. So you're not bound by just what the sort of canned reports are that come out of the registry. I think there are some very useful reports that come from the registry that for many programs, if not most programs, and for most situations will probably suffice for what you need. But I think if there are things that you want to do beyond just what's in these canned reports, you can have your data exported out of the registry, and then you can sort of analyze it and do whatever you want to do with it at that point as well. So so that it gives you some flexibility to do more than what's just in the available canned reports. So I think with that, I'll conclude my part of this and turn it back over to Hannah. And I think we have some time here at the end, hopefully, to answer any questions that folks may have.
We do. Attendees, if you have questions at this time, please feel free to submit them using the questions toolbar and the GoToWebinar toolbar. Marge, it looks like the first question is for you. We have an attendee who is wondering, what is C-suite?
Like the chief financial officer, the chief executive officer, the chief medical officer. Other people call them the guys in the suits, the suit suite. Basically, what I meant is the head of your hospital. Usually there's a executive group in a hospital that makes a lot of the decisions in it, but the people who actually do a lot of the work and implement the decisions are usually the next level down or 2 levels down, the managers or the vice president. At Helen Hayes, we're such a tiny spot. I was seeing a patient in outpatient cardiac rehab last night, and I'm the chief medical officer here, so we're, it doesn't mean that your C-suite is not approachable, but different hospitals have different layers of that you have to understand and go through.
Thank you. Attendees, we do have both Marge and Todd still on the line, so feel free to write in with questions for either of them. The next question, it looks like, is specific to the registry and wondering about identifiable information, such as date of birth. We're wondering how this is accommodated to ensure privacy are there any issues that other programs have experienced in regards to patient information and privacy?
Yeah, so there are PHI that are collected, identifiable health information. The connection between the data are stored on a server which is HIPAA compliant. So and it's firewalled and that type of thing. And then you log into either a website to enter your data, which has a secure connection, or some of our telemetry vendors have what are called APIs, or these automatic ways to upload your data from your telemetry system directly into the registry. So, and those are also firewalled or tunneled connections that are considered HIPAA secure. So, obviously the information security is of a high priority. I'm not aware of any breach of that thus far in terms of privacy violation, but great care is taken to ensure that the data are collected in a safe and compliant manner. But it does meet all the registry does meet all sort of HIPAA compliant collection.
Thanks, Todd. It looks like we do have some specific questions relating to the registry and how to enroll. If you're interested in enrolling in the registry, there is information available on the AACVPR website. There is a fee associated with accessing the registry, both for cardiac and pulmonary rehab, and those are both posted on the AACVPR website. The fee is determined by the amount of patients that you have in your program annually. So definitely check out the AACVPR website. There's a form you can submit to get more information and start the enrollment process for the registry. The next question we have is from a webinar attendee. They have written in and said, since 2012, they have made enrollment quicker for non-complex cases within 10 days of MI and PCI. In Maine, 3 of their commercial insurers in 2016 started enforcing no enrollment until symptom-limited stress tests with risk based on METs alone. 8 METs are low risk, therefore 6 sessions only. Do you have any advice?
I don't know. I mean, I think, yeah. I mean, I know a lot of insurers are trying to shorten how many sessions they're approving, other than trying to get your medical director to meet with these insurers individually to say, hey, look, these are the data in cardiac rehab, and I mean, there's great data that show that when you get past 12 sessions, there's improvement. There's a wonderful paper in circulation which showed that there's a dose response to cardiac rehabilitation. I think having to sit down and show them those data that say that more sessions results in more benefit, and that may be something that needs to be your medical director kind of meeting with them to discuss that. But unfortunately, that is an issue where folks are trying to cheat down the number of sessions in an attempt to save money. And your individual program, unless you can show data showing, the patients that went to our program have better outcomes, but that would be nice. But I think that may take a larger sample to be able to demonstrate what the benefit is. And so that may need to be a medical director to insurance company discussion.
All right. Another question is regarding discharge dates, or I'm sorry, intake. Which date do you consider the enrollment date? Is it the date that the initial intake assessment is done, or the first day of exercise? In this individual program, they do the initial intake first, and there are times when the patient never actually starts the actual exercise due to transportation, changing their mind, etc.
Yeah, I think the initial intake is generally what's considered the intake.
Yeah, and for the program, the outcomes measures, for example, the date would be when you collect the outcomes. So you're most likely collecting the outcomes during your intake for depression screening, for example. Or on the other hand, your first functional improvement outcome is most likely going to be collected on the first day of exercise. So I think it really depends on what you're measuring and how it's defined.
Yeah, and the other thing too is that for one of those functional capacity measures, the one that for the program certification performance measure is you can take, I think it's the 3rd exercise session, because it has to do one of the ones on number of METs while exercising in cardiac rehab, as opposed to like the peak MET or the 6-minute walk test. You take that on the 3rd session. So
a lot of this does depend on what it is exactly you're talking about.
Yes, and don't trust our memories. Go on the AACVPR website and actually read the metrics. They're well defined. The exceptions, exclusion, when you measure them, they're well defined in the document. So don't rely on Todd's and my memories about exactly what it is. But as we said, it's depending on what you're measuring.
Thank you so much. I do want to mention that if you have more specific questions regarding the registry and the information that's collected, how to enroll, or any other number of questions in regards to the registry, you can email registry@aacvpr.org, and we'll be able to help you with any questions you might have. It does look like we have a few minutes left, and we do have another question from an attendee. They're asking about registry discharge dates, and if you can clarify if this is the discharge date referring to the hospital.
No, so there'll be when we talk about discharge from cardiac rehab, that would be the completion day, the last session, when you recollect all your data. So now, if you're talking about discharge from the hospital, that would be before enrollment. So you could look at discharge from the hospital, or a discharge date from like an outpatient PCI or something. That would be your discharge date that would start the discharge to enrollment. And then once you enrollment to discharge from cardiac rehab or completion of cardiac rehab, completion is defined as whatever day they come in and do all their post-assessment. So when they redo their peak meds, or they redo their 6-minute walk test, or they retake their psychosocial screening and that kind of stuff.
And there probably is still, because I know there was, a data elements dictionary of definitions of all these things on the registry website.
All right, and we do have one last question. Is it important to track discharge to enrollment for cardiac bundles?
I don't know that for the bundle itself, it probably doesn't matter, but I think it's important for you to know your data, because if you're in the incentive program, and we didn't talk a lot about this today, but if you're in the incentive program, you only get paid that incentive, or the hospital doesn't get paid the incentive dollars after 90 days. So you really want to shorten your discharge and enrollment to maximize the number of sessions you can get in before the 90 days ends. And even if you're not in the bundle or the incentive, or if you're in the bundle but not in the incentive, and you're really trying to use cardiac rehab as your kind of transition of care strategy. In other words, when patients get out post-MI, you want to get them into rehab, because that's how you identify problems before they get readmitted to the hospital or show back up in the emergency room. So you want to know your numbers so that I think the idea here is to get people in as fast as possible and get them into the system, because cardiac rehab is a mechanism to prevent readmission. And then if you're in the incentive, it's the mechanism to get more money. So you don't have to report it necessarily for the bundle, I don't think, but I think you want to know your numbers, because it's going to be very important for your ability to be successful.
Well, thank you so much, Todd and Marge, for sharing your time today and your expertise. And attendees, thank you so much for spending the afternoon with us. If you have any follow-up questions, please feel free to direct them to registry@aacvpr.org or AACVPR@aacvpr.org. Thank you again, everyone. Have a great rest of your afternoon.